Hello everyone. As this class is going to stay recorded, I'll be starting. But don't blame me because I said I will start after 10 minutes, but I started within 5 because these classes are going to be long, long classes. And what do you need to do? Nothing. You need to do nothing. You just watch. You just watch. Why? Because you already know everything. You have already studied everything, and you will see almost 90% of the questions you have studied in our notes. So you will understand it. I will just show you how to approach. I will just show you how to approach why this answer is this, why this answer is that. Now, there are some like first thing, you stay mute. Why? Because I always say I hear different kind of sounds, and it happens. It happens. Some people do this, some people do that, and some people have sex. There are different kind of sounds, guys, and it gets recorded in our classes, and people feel uncomfortable. So you stay mute. Okay, and it happened, that's why I'm saying it. So stay mute. If you have a question, we have a question posting group. We have a question posting group. You post it there. You will not have any questions because we have already answered all the questions in our classes. You will see this. We will start from September 2024. And first, I would like to thank three people who helped me edit it. I would like to thank Dr. Rawatun Nobi, Dr. Humaira Bint Nasir, and Dr. Saida Nuri Jannat Norin. They helped me. They just helped me a lot. Like they talked to all the people who gave the exam from our courses, from here, from there. They collected it all, and their dedication is Unmatchable. Thank you. Thank you. Okay. See, first question we got is, in ascending aortic dissection, which vessels is first affected? Guys, see, ascending aorta, we all know ascending aorta. This is a very tricky question. This is a very tricky question because all we remember is B, C, S, brachiocephalic, left common carotid, left subclavian. But we forget that first branch is coronary artery. Coronary arteries are the first branch, right coronary artery and left coronary artery. You just, this question is tricky, but it's answerable. It's very answerable. Very answerable. When ascending aorta ends, arch of aorta starts. And these branches are mainly from arch of aorta. So, in ascending aortic dissection, only one vessel, like right coronary artery or left coronary artery, are in danger. Okay. So, then this is a very easy question, relation of brachial artery in cubital fossa. This is a very easy question. Just a recap from anatomy. Just see the picture, that will help. 20-year-old motorcyclist involved in a road traffic accident and fractures his temporal bone, completely transecting the facial nerve just distal to the geniculate ganglion. Guys, see, what's the trick of answering a question in MRCS Part A? See, you study a lot. You study a lot. When? Now. Now, what do you do? You revise. What do you revise? Everything I told you in class. See, these lines follow. I used the same words, and facial nerve. This is not a word anyway. This will always be facial nerve anyway. The same words in my notes, same words, in same way I have taught you everything. You will know every single question in your main exam. You will know it. Just you have to keep your head cool. How do you do that? You revise. You revise. What do you revise? Everything I told you. You will get a lot of questions, a lot of questions. A lot of people will be talking about a lot of things in various groups, in Telegram, in Facebook, everywhere. But remember, most of them are unimportant and will not come in your exam. Totally unimportant, totally unnecessary. They will not come in your exam. They will never come in your exam. So, and mostly EMRCS. Just forget EMRCS for these 2 months. Forget it. Forget it. Forget it. It will distract you like hell. It will just distract you. And a lot of unnecessary question will cloud your mind and you will forget the important ones. It will cloud your mind. It will cloud your mind and you will forget the important ones. So, what do? Everything, every single word I told you in the class, you revise. You revise. The way I told you, you revise them. You revise them. And then what happens? That's the first thing you do. Then what happens? Number two, watch the classes. Just watch the discussion classes. Just watch the discussion classes. Then number three, arrows. Arrows. Go through our arrows every day. Every day. Every day go through our arrows. Every single day. Every single day. You watch the arrows. You study the arrows. Okay. You study the arrows. These are three things you do in these 2 months. Okay. These are the three things you do in these 3 months. So, what do you study now? You revise from our classes, not only the notes. Revise from classes. The words I said that this will come this way. Just pay attention to that. Revise, revise, revise. Only those things you revise. Why? Because they will contain your pass mark. You will get your pass mark from there. You will get your pass mark. You will not have 300. You will not get 300, but you will get almost 200. Right, direct, and you will have your pass mark there. You will have your pass mark there. Almost, why did I say 200? You will have almost 250 because 10% are new question. If 300's 10% is 30, you will get 270. Okay, but you will not be able to remember 270. Everyone will remember 200 and will be answering correctly. No matter how hard the question is, no matter how new the question is, no matter how twisted and turned the question is, you will always get 200 straight out of my mouth. Straight out of my mouth, what I said in class. And you will remember those if you revise, and you will pass this exam. And 250, yes, if you can remember more, you will get it. You will get it. You will get it. You will definitely get it. Like highest score till now from our last three batches is 85%. 85% is a lot of mark. 85% mark is a lot of mark. Okay, 85% is a lot of mark. Okay, so everyone will get 85% if they remember everything I said, but no one can remember everything I said. So don't worry about 85 or 90%. Don't worry about that. What do? You study the notes made from classes. Then watch the recalls discussion classes. Then number three, go through arrows every day. You don't study recall. You don't need that. You don't read that. You don't need that. I will tell you what to study. You study the classes. Just watch the recalls. Then how to answer a question. You read the question three times. You read the questions three times. Every question in your main exam, you read it three times. Why do I say you read it three times? When you read three times, you will see that there are some words and something I have told you that if you find this only and only, that will be the answer. A thing, like anything you study, you read a question three times. What did I say? Every time I told you about facial nerve, you read this stem three times. And when you read three times, completely transacting facial nerve just distal to the geniculate ganglion, how many times I have told you that if they give you a question from facial nerve, they will involve geniculate ganglion, and they will tell you that the injury is distal to geniculate ganglion or proximal to geniculate ganglion or distal to stylomastoid foramen or proximal to stylomastoid foramen. Okay, but most of the time I told you about geniculate ganglion, right? Most of the time I told you about geniculate ganglion. So if you study it three times, you will remember my word. My words will play back of your head, and you will just remember lacrimation. You will just remember lacrimation. Or even if you don't, you will see that this choice is catching your eye. This choice is catching your eye. Okay. So, what's the step? First step, you read the stem three times, and in your mind, you will have an answer. In your mind, you will have an answer immediately. Immediately. And this answer will be correct in 100% of times if you revise more and more. If you revise more and more, this answer will be the correct answer in 100% of the times. So, what do you do now? You revise a lot and study the stem, read the stem three times. You will have an answer immediately in your mind, and you don't read the stems, you don't read all of it. You just search for that answer in the stem. You search for that answer came in your mind. You search for that answer came in your mind in the choices. You find that, you select that, you move on. Don't think. Don't think at all. You think now. You think now while studying. You think now. But during exam, no thinking. No thinking. Read the stem. Go with your gut. Your gut knows the answer. Read the stem three times, and you will know that this should be lacrimation. This should be lacrimation. So you search for lacrimation in the stem. You find that, you select that, you move on. You don't even read the next stems too. You don't need that. If you are this much sure that I have told you how many times that distal to geniculate ganglion, you will lose lacrimation. Very simple. So you don't need to read the stems, read other choices too. And why do we need that? Because there will be questions you will have no clues. So you save time here. You save time in these questions. So you can think about those questions. You can think about those questions. So you save time. You will need only 10 seconds to answer it. You will need only 10 seconds to answer it. So read the stem 3 times. You will have an answer in back of your mind. Back of your mind, my voice will play and it will tell you that distal to geniculate ganglion, lacrimation will be preserved. So you search for lacrimation. Third step, you find lacrimation, you select that and move on. Simple as that. And how did I teach you about that? Let me just recap, a quick recap of facial nerve. Just draw these two lines. This is our geniculate ganglion, this is our middle ear cavity, and this is our stylomastoid foramen. All the motor branches are after stylomastoid foramen. Okay. And here our superior salivatory and lacrimatory nucleus. So lacrimatory nucleus will give lacrimatory fibers. Salivatory nucleus will give salivatory fibers. And additionally, you get taste fibers from nucleus of tractus solitarius. You don't need that. Just remember superior salivatory and lacrimatory nucleus. Okay, these blue ones are taste fibers. Very easy. So lacrimatory fibers will come up to geniculate ganglion and it will be named greater petrosal nerve and it will go to pterygopalatine ganglion. Pterygopalatine ganglion. And from pterygopalatine ganglion, it will go to lacrimal gland and nasal mucosa, causing nasal secretion. Very simple. And then these salivatory fibers will go to middle ear cavity with facial nerve proper. This one is facial nerve proper. This one. Okay. And taste fiber, taste and saliva are very good friends. They are connected to each other, so they go together. But in the middle ear, they feel like they are going with the wrong person. They are going with the wrong person, so they change track. How do they do it? They change track behind your tympanic membrane, and it looks like a cord. And this is called chorda tympani. Chorda tympani, because it's behind tympanic membrane and it looks like a cord. So this is chorda tympani, branch of facial nerve, and with it we have salivatory fibers. We have salivatory fibers. And after emerging through petrotympanic fissure, guys, this chorda tympani, along with salivatory fibers, it will come out through petrotympanic fissure. And it will meet a new guy, a brand new guy that is like L. Okay. And with it, we have salivatory fibers and taste fibers. So this L is our lingual nerve, which will supply the touch, pain, and temperature of anterior two-third of tongue. And these blue taste fibers will supply taste from anterior two-third of the tongue. Will take taste actually, take taste anyway. Now, and the salivatory fibers will go to submandibular ganglion. Submandibular ganglion. From submandibular ganglion, we get sublingual gland and submandibular gland. Parasympathetic supply. Anyway, these these are the complete thing about facial nerve. Complete thing about facial nerve, and you will not get anything else from facial nerve. They will just say that there is an injury distal to stylomastoid foramen. So which function will be lost? So all motor function will be lost. And which function will be preserved? Above injury, everything will be preserved. Above injury, everything will be preserved. So above injury, we have taste. Above injury, we have lacrimation. And I forgot to mention one thing from facial nerve proper. It gives nerve to stapedius, which stabilizes stapedius. This is your revision, guys. So I told you just to watch the classes. This is your revision. So you don't need to study anything new. Stabilizes stapes. So you don't get too much sound. So it prevents hyperacusis, which is hearing too much sound. So everything above the injury will be preserved. Watch it from our notes. Now you know it very clearly. Okay, just a recap, just a quick recap. So anytime there is an injury in a nerve, the point of injury, if this is the point of injury, after it or distal to it, everything will be lost, and above it, everything will be preserved. Everything will be preserved. Then let's talk about muscle from lower border of quadrangular space. Watch it directly from our notes, teres major. Changes occur in prone position with ARDS. This is very simple. We know in COVID, uh, we know it from COVID that in prone position, ventilation perfusion ratio is improved. Now, reduction of functional residual capacity happens in obesity. Happens in obesity. Perfusion mismatch? No. Perfusion is quantity of blood. Perfusion is quantity or amount of blood entering lungs. So, to be a mismatch in perfusion, you have to have some clot inside it or something like that. Okay. Alveolar hyperventilation, no. We didn't get, could not remember another choice. So, we just, I don't know. This is a typing mistake. Anyway, so improved ventilation perfusion ratio. This is, we all know it. How? Because when you are supine, this is your vertebra. Let's say this is your heart, this is your liver, this is your lungs. So liver will press lungs, heart will press lungs, and we get low perfusion, lower perfusion. Okay, this area, this area behind will get collapsed. And already we have some problem, right? Now, if we flip the person around, what happens? These is your lungs, heart is here, and liver is here, and this place gets opened. Very simple. So we get increased ventilation. We are providing ventilation, right? We are providing ventilation. Perfusion will increased. So ventilation perfusion mismatch will be corrected or improved. Line of Zahn found in thrombus. Don't worry about it. Just study it from our arrows. Angle of mandible sensor nerve supply. Guys, I told you that if someone, if someone talks too much, what do we say? কানের নিচে একটা লাগিয়ে দিলে ঠিক হয়ে যাবে, জ্ঞান বাড়বে, ঠিক আছে? Very simple. Or কানকে নিচে. Okay, so greater auricular nerve is জ্ঞান, means wisdom or knowledge. Anyway, I don't want to say it because there are international candidates here, they won't understand. So we just forget it for a while. We just know that angle of mandible is sensory nerve supply is greater auricular nerve. We all know it. Patient on heparin, surgery is planned. How much time before it should be stopped? Guys, we all have it in our drive, in our notes. Just remember from coagulation cascade or which drug to stop when chart. Which drug to stop when? You will find it in our charts folder, and you will find it in our uh, perioperative note 2. Perioperative note 2. Now, see, you might get confused between 24 and 12 hours. See, here you don't even have 24 hours. You will not have it. They will not make you confused about it. What's the warfarin bridging? Warfarin, it is a question about warfarin bridging. See, just remember that we stop warfarin before 3 days, 3 to 5 days, depending on the situation. Now, we start low molecular weight heparin. And on the day of operation, we give half dose of low molecular weight heparin at morning. So then stop. Then stop. So that is said that 12 hours. 12 hours before the operation, we stop it. Just remember this thing. Nothing else is required. Just remember about this thing. Before 3 days, we stop warfarin and we start low molecular weight heparin. And on the day of OT at morning, we stop low molecular weight heparin after giving half dose. Then axillary nervous sensitivity shoulder, we all know it. Don't worry about it. Don't worry about all these choices. Don't worry about all these choices. You know it. You know it. See, only motor to deltoid. No, actually, it has nothing to explain. Checked by scapula elevation. No, scapula is elevated by accessory nerve and winging of scapula. We have long thoracic nerve and accessory nerve. If both damaged, can cause winging of scapula. Motor supply to deltoid and teres major. No, no, it's just plain anatomy, nothing to explain. Associated with profunda brachii, no, because with profunda brachii we have radial nerve, radial nerve. Okay, so only this choice makes sense. So maybe this for this question you need to think. Which question you don't need to think? This question. Find directly in our arrows. This question. Find directly in our notes and arrows and charts. This question. So we got 10 questions. We got 10 questions. Okay. We got 10 questions. And among that, almost one, two, three, four, 5 questions. I mean, 50% you don't need to think at all. Don't need to think at all. You get 10 seconds. That's how you save time. So just revise with me. General sensory supply by facial nerve include. You remember from my class, I told you, like in every batch, I told this thing that there is only little general sense. What is general sensation? Touch, pain, temperature. And facial nerve has only a little area of general sensation that is in external auditory metas, that is above temporomandibular joint. Just remember these two words. If you get a question from general sensory supply facial nerve, you will get two choices. Either they will ask, where is it? It's in external auditory meatus. Or where is it? It's above temporomandibular joint. Patient presented with chest injury and pneumothorax, and chest tube was inserted. Read the stem 3 times. In fifth intercostal space, continuous bleeding from chest. Do you think the question in the exam will be just these 2 lines? No. It will be a long stem with various things mentioned. But just remember chest tube. Just remember bleeding from chest tube site and intercostal space. Chest tube was inserted in intercostal space. So they are just asking the way I told you in class that if there's any bleeding during thoracocentesis or chest tube insertion or needle decompression, remember it's always from the artery. So just say I told you it's always from the artery. So of course it will be from intercostal artery. I don't need to explain it more. But you might get confused with superior intercostal artery. So there must be an inferior, but see, they will not give you an inferior intercostal artery as a choice. These choices are pretty straight, and you will understand if you get my clues. Descending aorta, not possible. I told you that will always be an artery. That will always be an artery. Which artery? Intercostal artery. I admit, I didn't tell you about superior or inferior intercostal artery. I just told you that will be intercostal artery. Okay, so you just find one intercostal artery in your options and you see superior attached with it. Don't bother about it. Don't bother about it. Just select that. Just select that. So just select that. Then on DRE, some heart structure was found posteriorly from anal verge. Very easy. Very easy. People might say levator ani. Yes, that's a part of levator ani. That's a part of levator ani. What do they do? What did they do? They just didn't give levator ani, but just gave one component of levator ani. One component of levator ani, that is puborectalis. That is puborectalis. Did I attach a photo? No. Okay, we have a photo in our flashcards. Watch our flashcards for photos. Patient with heart rate 72. See, this is nothing to explain. This is just calculation of cardiac output, just heart rate into stroke volume. See, and what did I say? I forgot to mention one thing. This is a single best answer. So you will not get accurate answer. Always you get, they will give you five choices. They will give you five choices. And what do you do? What do you do? You select the best one from the choices. Best one, nearest one. What's the difference between best one and nearest one? See, all of the five choices can be correct. All five can be right, but there will be one best from all four. How do you know which one's best? Revise from my classes. And nearest one. All five choices are wrong or not right, doesn't feel right. But there is one choice that feels more right than given options. More right than given options. So that will be your answer. You just choose the best option from the given option. You don't invent something in your mind and say, the question is wrong. These choices are not good. There are better choices. Yes, there are better choices. But maybe they are thinking about a hospital where you don't have that facility. Okay, let me give you an example. What will be the example? A pregnant woman needs a CT. You know, CT is the best. You know, CT is the best for a pregnant woman with soft or perforation, perforation. Pregnant woman with perforation or abdominal perforation. Anyway, so you know, CT is the best thing to do. But in your choices, you have erect X-ray abdomen, you have MRI, you have other choices, let's say. But CT is the best option. We have studied it. CT is the best. But you don't have it here. So what do you choose? You don't answer. No, you don't do that. You answer. And what's the best? Erect X-ray. Here, erect X-ray is the best option. So you choose that. You don't leave a question. You don't leave a question because there is no negative mark. There is no negative mark. You don't leave any question. Not a single one. Stab injury to buccal branch will cause damage to. So this question is not clear. Why it's not clear? Because the people who remembered the question, they couldn't give us more details. More details. See, maybe they were just asking that here is our buccal branch of facial nerve and a stab injury near it. Stab injury near it will damage which of the following structures? So this is understandable. See, even if you don't know where buccal branch goes, like we all know, like five fingers, if we put it like this, five fingers, we will have an idea that temporal, zygomatic, buccal, this, okay. Let's say this is the face. I'm not good at drawing. Temporal, zygomatic, buccal, marginal mandibular, cervical. Temporal, zygomatic, buccal, marginal mandibular, cervical. So we have an idea that this will go to head, this will go to cheek, this will go above upper lip, this will go in our mandible, and this will go to our cervical region. So a stab injury should be here. So here we have our upper teeth. Now we all know that submandibular duct is under mandible. So we should injure marginal mandibular nerve. Lingual nerve is inside, not inside, like it's above. It's it's related to mandible. We all know. And the thing I want to tell you that there are two nerves. One enters mandible or inside mandible, and one is above mandible. Over. I will say over. Over is the more correct word. Over mandible. Over mandible. Inside your mouth. So the one that enters, that is inferior dental nerve. And the one that's above mandible but inside your mouth, that's lingual nerve. So they ask this question that there is a nerve that enters mandible. What's the name of it? It's inferior dental or inferior alveolar nerve. And it comes out from mental foramen and it's named mental nerve. Very simple. Okay. Then marginal mandibular nerve. See, look at the options. You will understand that these cannot be the answers. And lingual frenulum is on floor of mouth. Buccal branch doesn't go near anywhere near floor of mouth. So you will understand it. Child with gastroparesis, and what's the time period which gut enter abdomen in fetal life? Watch our fetal circulation video. Watch our fetal, no, gut rotation video. We have a little 3-minute video of gut rotation, and this is very beautiful video. Just watch it. Just watch it. It will help because they ask about all milestones, all the weeks. What happens in which week? Which nerve originates from pontocerebellum? Facial and vestibulocochlear. We all know it. We all know it. Okay. Okay, I will show you a picture of it. I will show you a picture of it. Just post if you have more question about it. You can post it in question posting group. I will provide a photo with which nerve originates from pontomedullary junction. Pontomedullary junction 6, 7, 8 and pontocerebellum only 7, 8. We just need to remember these two. Okay, we just need to remember these two. Still, you can. We have a picture, but still, if you need it, ask for it. 6 weeks of all of the following flaps and their corresponding blood supply are correctly paired, except, guys, see, this is understandable. This is that 10% question which will come new question and will not fail for this exam. What will I tell you? You do not memorize recalls. Do not memorize recalls at all. You will fail brutally in your exam. Don't do that. What do? But there are some questions. If those come, will come directly with the same stem, with the same choices, with the same answers. And this is one of those questions. This is one of those questions. So you memorize this one because there are some questions, they are new. And what do? If they repeat that question, it will come the same way with the same choice with the same stem. So don't worry about it. Here is the chart: 6 weeks, 8 weeks, 9 weeks, 11 weeks, 12 weeks. Anyway, 27-year-old male presents with spinal shock after a high speed motor vehicle accident. He exhibits flaccid paralysis, areflexia, and urinary retention. Above which of the following spinal levels will the patient be at risk of developing autonomic dysreflexia? Guys, see, this word, I don't know if they gave it or people who recalled, they gave it. They just give symptoms. And this matches that they are giving symptoms. Okay, they are giving symptoms. But autonomic dysreflexia, I don't know. I don't know if they used it. We have attached a simple explanation. Just remember that above T6, the high above T6, if a person is transected, spinal cord is transected, then that person can develop autonomic dysreflexia. Just the way it is. Just the way it is. Just the way it is. If they give this question, they will give with the same stem, same choices. Then, a female post mastectomy patient presented with difficulty raising her arm and a winged scapula. Which of the following true regarding origin of the affected nerve responsible for this presentation? Guys, this should be our long thoracic nerve. Okay. And I would like to show you a simple thing just to recap. Where is it? Give me a minute. See. Just a quick recap because you people make a lot of mistake in upper limb from our notes. Remember, see, guys, I don't have to show you, see. Every time there is an injury, I always tell you it will always be from intercostal artery. So you study the notes, guys. You study the notes from our classes because I have told you how the questions will come. Okay, let me just show you a little bit of upper limb. And what do you study? Just a moment. This one, guys. This is your here. You can see it very clearly. This is your long thoracic nerve. This is your long thoracic nerve. And I told you during our studies, I told you during our studies that you should study only long thoracic nerve and suprascapular nerve coming from supraclavicular branches from roots of, this is from upper trunk and this is from root of brachial plexus. We don't have a better image. I will provide you one. I will provide you one. Don't worry about it. Branches from, no, we have it. Branches from root, long thoracic nerve from three trunks. C5, 6, 7. Okay. C5, 6, 7. So I told you during studies that you must know these two, long thoracic nerve and suprascapular nerve. You must know that these two comes from supraclavicular branches and from root. And from upper trunk, we have nerve 2, subclavius, and suprascapular nerve. So how do they ask question? Very simple. Very simple. Look at how they ask this question. A person is having winging of scapula. What did I say you about winging of scapula? If a person has winging of scapula, you see what's the operation he or she undergone. If it's a posterior triangle procedure, any posterior triangle procedure, accessory nerve is injured. If it's a mastectomy or axillary dissection, the injury is in long thoracic nerve. So they told you that a person had mastectomy, then she is having winging of scapula. So which is true about the nerve? So you have to assume the nerve. From our classes, you already know it's long thoracic nerve. And here is written in yellow box with highlight that it comes from roots of brachial plexus. It comes from roots of brachial plexus. See, 5, 6, 7. Remember this thing. See, 5, 6, 7. Next time they might ask what will be the root. See, 5, 6, 7. Very simple. So this will be your answer. Okay, just a quick recap. Then let's go back. Okay, then homeless man with ecchymosis and wounds not healed, reabsorb not healing wounds. Remember, anytime there is an ecchymosis, bleeding, and wound not healing, or any of that, wound not healing, or any of that, without any reason, that's a vitamin C defect. That's a vitamin C. That's a vitamin C. Okay, if alcoholic is mentioned and there is bleeding, that's a vitamin K. Okay, alcoholic means in your question, alcoholic means like not in general life that every alcoholic has liver cirrhosis. No, but in your Mrcs part A, if they mention alcoholic, they are telling you that that person is having liver cirrhosis. If they say lifelong smoker, that means they are just saying that person is a COPD patient. Simple as that. Okay, vitamin C. Anytime you see wounds not healing, vitamin C in Mrcs part A. Vitamin C. Do you need other vitamins? No. No, just remember vitamin A that we get night blindness. Night blindness. Other than that, not so important. They don't ask anything about it. Vitamin K, they ask about vitamin K dependent clotting factors. Okay, 2, 7, 9, 10. Very simple. And they ask about another thing. No, not now. Not now. We have it later. Apical non small cell cancer is planned for resection which will cause. See, I told you any tumor in the apical part or apex of lung, any tumor, any tumor in the apex of lung, that can be small cell lung carcinoma or non-small cell lung carcinoma or anything, or Pancoast tumor or superior sulcus tumor. What will be the questions you get asked? What will be the questions you get asked? Number one, they will ask you what will happen. Horner syndrome will happen, ptosis, meiosis, anhydrosis. Why Horner syndrome will happen? Compression of C8T1 or mostly T1. Mostly T1. Number 3, what is happening? Why this is happening? Guys, 1 minute. Give me a break. I will be back. Guys, I'm back. Okay, let's start again. Okay. What will happen? Horner syndrome. Where will be the compression? C81. Why are we having ptosis, meiosis, and hydrosis? Because of compression of sympathetic ganglion. And which ganglion is here? Stellate ganglion. Everything, every single word is important. And you will have this in your question. Stellate ganglion. Okay. And why is meiosis happening? Myos is happening because of this imbalance. What is the balance? This is our pupil. Constriction is done by parasympathetic supply, and dilatation of the pupil is done by sympathetic supply. So any one, if damaged, other one will have. This is a balance. These two opposes each other. If any one of it is damaged, other one will cause unopposed action. So parasympathetic will cause unopposed action and we get pupil constricted. Simple as that. And all of these things are very, very important and remember it. Just a recap, because we have already told you everything in our class. Patient presented with dysphagia, with liquids and history of intermittent regurgitation and halitosis. He is unresponsive to antacids. Antacids. Contrast study reveals a smooth narrowing of lower esophagus. Guys, we don't know the age. Maybe in your exam, you had that age, but people couldn't remember. This must be a young guy, like in his 20s or 30s. See, smooth narrowing and dysphagia to liquids. What did I tell you? What did I tell you? What is achalasia? Achalasia is failure of your lower esophageal sphincter. Esophageal sphincter. Now, why do we have dysphagia with liquids? Why we can't swallow liquids and first we can swallow solids? Because solids, we will press it, we will push it, and it will get some restriction, but it will pass eventually. Because of the push, because of the push we do, because of the push we do, solids will pass, but liquids we can't do that. We can't push liquids, so it will be collected here and solids will pass. So dysphagia to liquids, from liquids to solids. So there will be one time that this lower esophageal sphincter will be so tight that even no matter how hard you push, you can't even push the solid too. So at that time, you will have dysphagia to solid too. So first you will have dysphagia to liquids, which will be collected here and which will cause a very bad breath, which will cause a very bad breath, which is termed as halitosis. So you will get only you will get halitosis in only two cases. In only two cases. Now in MRCS part A, either it will be achalasia or it will be pharyngeal pouch or Zenker's diverticulum. What is a Zenker's diverticulum? It's a kind of pharyngeal pouch, but in between your inferior constrictor muscles, inferior pharyngeal constrictor muscles. We can have pouch in between a lot of muscles. When it happens between inferior pharyngeal constrictors, we call it a Zenker's diverticulum. Very simple. In trauma, body's mechanism to control thrombosis, we all know it. Guys, whenever there is a trauma, whenever there is a trauma or something or an inflammation, our endothelium gets activated. Endothelium, what is endothelium activation? Endothelium shrinks, very simple, and makes gaps, and whenever there is a naked basement membrane, the basement membrane is exposed, and we have bhai brothers in our basement membrane, and platelet just immediately stick there, immediately stick there. and start a coagulation cascade, and it forms thrombus. But we have healthy endothelium too around it that maybe they are not activated. Now, let's say here we have coagulation going on, but here we have a healthy endothelium. From here, some thrombus can come here and cause damage. So, a normal healthy endothelium secretes plasmin, of course, plasminogen in active form. Then it becomes plasmin. Guys, let me tell you. Healthy endothelium will secrete plasminogen, and we have tissue plasminogen activator. We have tissue plasminogen activator from our blood. So this tissue plasminogen activator will activate plasminogen and make it plasmin. Plasmin will break fibrin. Very simple. So fibrin is a clot. Very simple. Fibrin is a clot. And plasmin cuts the clot. Simple as that. So anytime there is a massive trauma in our body, there is a massive trauma in our body. I don't want to make it complicated. This is the serial. Plasminogen is activated by tissue plasminogen activator, and it becomes plasmin, and plasmin cuts fibrin or clot. This is the first thing you need to remember. Stay with me. Then the second thing, as we have tissue plasminogen activator in our serum, in our blood, we have tissue plasminogen activator inhibitor too. Whenever there is a massive trauma, from the studies we know it, it's a big mechanism. There are a lot of theories. I'm just telling you the gist of it. I'm just telling you the gist of it. Only the words you need to remember for MRCS part A. Whenever there is a massive trauma, we lose a lot of tissue plasminogen activator inhibitor. We lose a lot of it. So there is a lot of tissue plasminogen activator in our circulation, and it will make a lot of plasmin out of plasminogen, I mean from plasminogen, and it will break fibrin or the clots, and this is termed as hyperfibrinolysis. Okay, so in trauma, body's mechanism to control thrombosis all over the body, that is plasminogen. Okay. Activated protein C? No. Activated protein C works in a different way. Antithrombin 3? No. Thrombomodulin? We all know it from our coagulation class. I will tell you, just give a quick recap from coagulation class. Tissue factor? No. Tissue factor? No. Just remember this one, plasminogen. Just remember this one, plasminogen. Anytime, they ask you two questions. Hyperfibrinolysis caused by plasminogen or plasmin. Okay. And anytime there is a massive trauma and body wants to control thrombosis, this plasmin works more. Why? Tissue plasminogen activator works more because tissue plasminogen activator inhibitor is gone. Just remember this thing. Hydrocortisone is superior to dexamethasone. Because of what? Because of more mineralocorticoid action. There is nothing to explain about it. You memorize it as it is. If it comes in your exam, it will come with the same stem with the same choices. Okay. It will come with the same stem with same choices. You don't need to know all of these things. You just need to know why hydrocortisone, why specifically hydrocortisone is superior to dexamethasone because of its more mineralocorticoid activity. A young lady fit and well taking steroids, and her wounds are not healing on tibial shin. Reason for non-healing wound. We all know it. We all know it. See, wound location. This one's partially true. Blood supply. This one's partially true. Diabetes not mentioned. They told you that she is fit and well, so there is no diabetes. Infection, that can be a cause too. But which one is the best? They did not mention any clue about infection. No pass mentioned. No discharge mentioned. No pain or fever mentioned. No temperature mentioned. Nothing mentioned. So you don't suspect which is not there. But see, what did I tell you? You will have, you can have more than one right answer, but you have to choose the best one according to the scenario. Okay. So TBL shin, yes, the if steroid was not there, wound location will be the answer. Will be the answer. Why? Because the distal your wound, distal your wound from the heart, it will heal more slowly. So that's the reason. We all know it. We all know it. Okay. So here, steroids is the best answer because they mentioned she's taking steroids, and steroids delay wound healing. And if we measure the degree, wound location and steroid, wound location both, wound location and steroid both delay wound healing, but which one more? If steroid delays wound healing 100 times, wound location compared to steroids will do it 50 times. Okay, so this one is the best answer here. This one is the best answer here. During pericardiocentesis, which one of the following layer is pierced first as needle is inserted? That is very beautiful question. Just see this. Just see this. Just see this. Just see the serial. Fibrous pericardium, then parietal layer of serous pericardium, and if there is a fluid or blood, it will be collected here. It will be collected here. Then visceral layer of serous pericardium, that is on epicardium. That is on epicardium. Then myo, then endo. Very easy. Very simple and easy question. So this question can be asked that which one is the last layer? The second one is the last layer. That is, this one is the first layer and this one is the last layer. Very simple. Parietal layer of serous pericardium before getting the blood or getting the water. Anyway, first site of hematopoiesis, nothing to explain. We all know it. York sac. Please memorize it with all your heart. Site of emergency tracheostomy. C. This is the question you need to be worried about. Okay. C. Emergency. What do we do on emergency? We pierce the cricothyroid membrane. And the cricothyroid membrane is above cricoid cartilage and under thyroid cartilage. So our thyroid cartilage is our Adam's apple. And we approximately go down 1 centimeter. Very easy. If you know cricothyroid membrane, just remember cricothyroid membrane is pierced during emergency tracheostomy, and you will see everything makes sense. One finger above sternal notch? No, sternal notch is here. One finger? No, it's we can't do that. The hair is nowhere near cricothyroid membrane. Midway between sternal notch and cricoid? No, no. Here's the problem. Midway between sternal notch and thyroid cartilage is our site of regular tracheostomy. Regular tracheostomy. And the people who blindly memorized the recalls, they marked this question wrong because they forgot. emergency tracheostomy, because the stress level is high and you cannot remember tiny details. That's why I told you revise, revise, and revise. 1 centimeter above sternal notch. No. 1 centimeter below cricoid cartilage. No. We pierce above cricoid cartilage in emergency, not below. So 1 centimeter below thyroid cartilage is the best answer here. Then parasympathetic nucleus of superior salivatory nucleus. Guys, you can be confused about inferior salivatory, but if you have done my classes, you know your on back of your head, you will just remember that you have heard tell me superior salivatory and lacrimatory nucleus a lot of times. And I intentionally do these things because these words come in your exam. These words, I choose only those words that come in your exam so you can remember better. Superior salivatory and lacrimatory nucleus. I have entered into your subconscious mind, and in your exam, you will see I'm talking to you that this will be the answer, and that will be the answer. You will just see it very clearly. Then one day, an old baby have a laparotomy, transverse incision is made. You will find structure from umbilicus goes superior laterally. Guys, this is a very easy question. I have explained it in pediatrics too. And everywhere, every time I told you about fetal circulation, just watch the fetal circulation video or pediatrics class. I have told you about these things, See, from umbilicus, we will have one umbilical vein going to liver. It will carry oxygen rich blood. Okay. And we will have two umbilical arteries. Here is not shown. Here it's not shown. Let me just. This is your umbilicus. This is your umbilical vein. This is your umbilical vein. And you will have two umbilical arteries. Umbilical arteries. They will carry de oxygen devoid or deoxygenated oxygenated blood from fetus to placenta. Then you will have one to your digestive system and one to your urinary system. Urinary system. Okay. And urinary system, we call it urachus. Okay. Then when you cut the umbilical cord, all of these things, remember, this is your vitalointestinal duct, that is intestinal system. I told you that is, and if this is your vitalointestinal duct, okay, in your digestive system, but right now we don't need it. We just, okay, all of this becomes a remnant. All of this becomes a remnant. This one becomes ligamentum teres hepatis. This one, these two becomes medial umbilical ligament, and urachus becomes median umbilical. Remember N, umbilical ligament. You just need to remember these four things or three things, whatever. So this one will go up superiorly. These two will go laterally. Okay, named medial umbilical ligament, and this one will go down. Just see this picture. This one will go down, or you know that if you remember this, that this goes to liver and this comes back, and these are two ligaments, two medial umbilical ligaments, so they are just talking about one. So one goes superior laterally, That is ligamentum teres hepatis. Okay, ligamentum teres hepatis, that is umbilical vein. Okay, so urachus, umbilical artery, vital intestinal duct, ductus venosus, no. Ductus venosus, no. Ductus venosus is after liver. This is ligament, umbilical vein, go to liver. And in liver we have okay, watch our circulation video, we have to talk a lot. Okay, so in liver we have ductus venosus. We have ductus venosus from liver to our IVC. Okay, ductus venosus. Just in short, I just told you. Okay, then a patient had MI 5 days ago. Now admitted vitally unstable. Aortic balloon pump was placed and shift to OT. Aortic balloon pump is placed for what? Guys, this is just nothing. This is just a plain question about MI complication. Complication of MI. Complication of MI. Within 5 days. Number one, left ventricular wall rupture. Very simple. Very simple. Just study it as it is. Just study it. This is a new question from the 10%. Just memorize it as it is. Just memorize it as it is. There's nothing to change. If this question comes, this question will come the same. Distal ankle injury. And now you know why the pass mark was only 64%. Now you know. Okay, only 64%. So distal ankle injury, no fracture. Patient had pain in lateral malleolus, while pain in inversion. Which one is injured? Anterior talofibular ligament. Why? Because this is the most common. This is the most common ligament that is injured. This is the most common ligament. When your palm is inside, that is in inversion injury. The most commonly injured ligament is anterior talofibular ligament. If you don't understand which ligament to answer and it's an inversion injury, go for anterior talofibular ligament. It will always be the answer because that's the most common. Other ligaments injury is nearly zero. Patient presented with recurrent episode of dyspepsia and diagnosed as carcinoma in lower esophagus. In which epithelium this carcinoma is developed? Very simple. They're just asking esophageal lining. Very simple. Very simple. And I told you just study two linings, one of esophagus and one of your anus. Very simple. 11-year-old with pruritus ani and scotch tape test shows eggs. Anytime you see eggs on scotch tape, that's enterobius and you give mebendazole. Very simple. Anytime you see larva or bloody stool, that is amoebiasis, give metro. Just remember these two. Others, forget. Esophageal carcinoma compression anteriorly level T3. Very simple. Trachea. I told you trachea bifurcates at T5 or T4 lower border, but you don't need to know T4 lower border right now. Just remember T5. So above T5, after C6. Why? At C6 we have cricoid, and here esophagus, pharynx becomes esophagus, larynx becomes trachea. So from C6 to T4, any tumor, the immediate anterior structure is trachea. So trachea will be compressed anteriorly. But if it's at the level of C6, there will be no problem with respiration. No problem with respiration. Why is that? Because trachea has C-shaped cartilage, C, and behind it we have membrane, and here we have esophagus. If we have a tumor, it will press on this membrane and we will get breathing problems. But if we have a tumor at C6, we will not have breathing problem or it will not interfere with respiration. Why? Because at C6 we have cricoid cartilage, which is a full round cartilage There is no membrane behind it. It's a full cartilage, full ring. It's a full ring of cartilage. So there will be no problem with respiration. No problem with respiration. Human bite organism, just memorize it as it is. Cells in TB, we all know macrophage with giant cell, that's a granuloma. Granuloma, epithelioid, epithelioid granuloma. Guys, and others, neutrophil, epithelioid granuloma, we have it maybe in Crohn's disease. Crohn's disease. Then neutrophils, acute inflammation. Eosinophils, if we have ascariasis or worm infestation. Basophil in case of hypersensitivity. Hypersensitivity. Basophil and mast cell contain IgE and histamine. Basophil plus mast cell. Remember it. Cells in normal healing wound after 4 days. So it's an acute inflammation. Okay. Within 2-3 hours, neutrophil comes. And after that, macrophage will be dominant. Okay. Fibroblast is after healing. Myoglobin, you will find it in rhabdomyolysis. Rhabdomyolysis. That is, you will be given a stem about a marathon runner or crush injury, crushed limb for more than 6 hours or 6 hours or 4 hours, and he is having red urine. Why is he having red urine? Because myoglobin, his skeletal muscle or muscles have been broken down, and myoglobin is passing through urine. So what happens? What do? You give normal saline. How much? A lot, until the urine turns white. Okay. Myoglobin causes red urine after running or after crushed limb. After tissue trauma, what is first action by cells? Guys, see, here is a problem. Here is a problem. See, I we talked about it about those who collected the recalls. We talked about it. See, margination, margination, then tethering, rolling, adhesion, transmigration. So, do you need to know all? Do you need to know all? No, no, you don't need to know all. Just memorize it as they didn't. They just gave the choices and they asked you which one will be fast. But we don't know if all those options were there. All we know that most of the people told us tethering. Only thing they remember tethering, and some people remember low rolling, slow rolling, and adhesion transmigration. We don't really know. That's not really reliable. What you do, you just remember the serial. You just remember the serial. Okay, you just remember the serial and which one comes first in serial from your choices, you select that. You select that. Okay, you just remember the serial. Mechanism of action of lignocaine, we all know blockage of sodium channel. So from our arrows, you will find it 100%. Very important. Which one of the following neurotransmitter are secreted from nerve ending? We all know acetylcholine. Very simple. And which nerve ending we really don't know. We have GABA, we have see, this is a very easy question. GABA is secreted mostly inside brain. It's an inhibitory neurotransmitter, inhibitory, and these are secreted by adrenal medulla. What do we have? We have hypothalamus. Hypothalamus maintains our autonomic nervous system. Hypothalamus maintains our autonomic nervous system. They signal sympathetic chain anytime we need a sympathetic reaction. Sympathetic chain will secrete acetylcholine. Acetylcholine will go to adrenal medulla. Adrenal medulla will release epinephrine and norepinephrine to all over the body in our circulation. Naloxone reduces opioid effects, competitive antagonist, just the way it is from our arrows. Child with ventral opening on penis, ventral, remember ventral and dorsal. Ventral and dorsal. Dorsal epispadias, ventral hypospadias. Very simple. Treatment hypospadias river, very simple. And anterior is normal. We all have our opening on anterior side. So don't get confused with anterior and dorsal. Dorsal is abnormal, anterior is normal. Patient with bitemporal hemianopia and mass in brain in CT scan, it is derived from ectoderm. Very simple. They are just asking craniopharyngioma. They are just asking about craniopharyngioma, pharyngioma or pituitary tumor. Pituitary tumor. Okay, and mostly it's from ectoderm. Very simple, just the way it is. Just memorize it as it is. If it comes, just specifically only those questions. Specifically only those questions I mentioned. If come, will come with the same stem with same answer. Others no, they will change the stems and they will change the options. So be very careful about it. Loss of sensation on dorsum of foot with loss of dorsiflexion, sensory loss of web space first and second metatarsal. L45. Guys, just we all know it. We all know it that anytime your dorsum of foot sensation is gone, it's L5. Okay, now what did they do? What did they do? They added S1 with it. See, S1 we all know it's on the lateral side of foot. So that will not be answer. Just say you just know L5 will be the answer. But we have L45 and L5S1. See, we all know S1 is at our little toe. Little toe. So S1 will not be the answer with loss of dorsiflexion and sensory loss in web spaces of first and second, not the last. So this is not an answer. S2, 3, 4 keeps the poo off the floor. It's perianal area. Perianal area. Very simple. S1, S2. No, it's back of your leg and up. Back of leg and up. So only if you knew that L5 is the answer, you will go. The best one will be L4 and L5. You don't need to exactly know all of it to answer. Okay. Obese patient with increased appetite and eats a lot from where the hormone is released and responsible for overweight. Guys, yes, adipocytes. How? Let me tell you how. See, when you eat a lot, you get a lot of fat cells, and fat cells will have estrogens. Just in shortcut, will release estrogens and cause weight gain. Weight gain. Okay. So those males who are a little bit fat, be very careful about it. Lose some weight. Pylorodial sinus and pain. Pain is caused by prostaglandin E2. I have told you during our studies, find it in our arrows. Okay. Patient is allergic to medication and that medicine is given and develop anaphylactic shock. Guys, anytime anaphylactic shock you see in your stem, remember either they will ask you which one is responsible. IgE is responsible. Number two, which one releases histamine? Remember mast cell, basophil, both releases histamine. Where is IgE located? On mast cell and basophil membrane. We have IgE. IgE, and inside we have histamine. It's like this. Cause, the cause is IgE. released from, released by, অথবা carried by. If they ask carried by mast cell, very simple. Eosinophil, we all know, worm incision, hookworm, and other worms. Macrophage, neutrophil, no. Patient with familial coronary artery disease, any coronary artery disease, be it familial or non-familial, or if they ask about a smoker, or if they ask that which lipoprotein is bad, or which one is the leading cause of atherosclerosis, remember it's low density lipoprotein. Note down all four: coronary artery disease, number two, smoker, number three, which lipoprotein is bad, number four, leading cause of atherosclerosis, LDL. Atherosclerosis in a smoker or long time hypertensive patient, that is low density lipoprotein. Low density lipoprotein, guys, don't get don't get worried about it. It happens in Parkinson's. So this is the medicine related thing, and that will never be an answer. 16-year-old boy with hypertension and presented with aortic dissection. Hypertension, a young boy with aortic dissection. Young boy with aortic dissection is always either Marfan syndrome or Ehlers-Danlos. Now, you don't worry about Ehlers-Danlos. That is not so common in MRCS Part A, but Marfan is very common. Marfan is very common because it's a part of men to be too. So, what happens? This is and what's the cause of aortic dissection in Marfan syndrome? Cystic medial necrosis. We all know. We all know why, because we have um, elastin fibers. Elastin fibers. It's a defect of elastin fibers, and here is our elastin fibers, and we have a binder of elastins. In Marfan syndrome, we have problem with these hooks. We don't have them. So our elastins are far away from each other. They don't create a true bond. And and just as we know, tunica intima, tunica media, and adventitia media has elastic fibers, elastins, and these elastins are loose. They are not in a good quality. When there is a pressure of 120 millimeter mercury in our aorta, what happens? These cannot bear the pressure, and there is a tear. That is called dissection. That is called dissection. There is a tear. There is a tear. Now, they cannot bear the pressure, and they get damaged, and they get necrosed. So this is the first step: damage and necrosis. Number two, weakening. Number three, tear. Okay, damage and necrosis. And these necrosis, when first seen under the microscope, it looked like a cyst, but this is not a true cyst. Not a true cyst, because by definition, a cyst is something that contains fluid inside, but it does not contain any fluid. It just looked like a cyst. That's why they named it tunica medial necrosis, that looks like a cyst, or cystic medial necrosis. Very simple. This one will be the answer. Granulomatous necrobiosis, you will find it in rheumatoid arthritis. High blood pressure, not important. Atherosclerosis, if that's a smoker and in his 50s. Atherosclerosis will be The most common cause at this age, and cystic medial necrosis will be at this age. Very simple. Oral anticoagulant patient with needle phobia. Very simple and very easy. We use rivaroxaban. And if they say dabigatran, that can be an answer too. Why not warfarin? You can say warfarin is oral. We all know it. We all know it. We all know it. Warfarin takes time to work. Warfarin takes time to work. Like if they say that it takes 4 days. If we say it takes 4 days, just to say these 4 days we have to give low molecular weight heparin, and low molecular weight heparin is only found in enoxaparin or something, only found in injectable form. We give it subcutaneously. So if we use warfarin, still we have to give injection for some days. So we go for directly rivaroxaban or dabigatran. Female patient is being operated for femoral hernia. Bleeding started. Which structure form the lateral wall of femoral canal? Very easy and simple. We don't need to explain about it. Femoral vein. Carcinoma of uterine fundus. Lymph nodes drainage of uterine fundus. Guys, just see it from our charts. You might get confused that this is the fundus and what will be the lymph drainage. See, from fundus it goes to pre-aortic and para-aortic nodes, and body has parts, okay, and aortic or lumbar nodes. Then you have to see the chart. I will show you the chart, don't worry about it. I will show you, give you the chart. We have it in our charts folder. Horseshoe kidney, we all know it. Hilum of horseshoe kidney at which level? In between L3 to L5. Why is that? Because just remember, horseshoe kidney is attached at lower pole. Okay, hilum is here. Hilum is here. Okay, hilum will be here. And it's attached at lower pole. And where does it stops descent? It stops at the level of inferior mesenteric artery, because inferior mesenteric artery is at L3. Inferior mesenteric artery at L3. So we will have the hilum at the level of L3 if it's descending, or up to L5. Okay. So what are the questions? Number one, where is horseshoe kidney attached? At lower pole. Number two, where will it stop descent? Where will it stop descent? At L3 or inferior mesenteric artery. Number three, where will be the hilum? Either at L3 or L5, but not above that. Not above that. Not above that. A patient has the following pressure measured: hydrostatic capillary pressure. Very easy and simple question, guys. And I felt very happy that this question came. I told my candidates during we have calculation videos, CPP, hydrostatic pressure. I just told, what do you do if you get this question? And they had very possibility to get this question in September exam. And I told them, what do you do? You just get the biggest number, 35, minus all the numbers. Don't worry about this thing, that thing, capillary hydrostatic, capillary this, oncotic, Bowman. Don't worry about it. Just take the big one and subtract the little ones. 27 plus 0. So you get 27 plus 8 is 35. So it's plus 8. Very simple. Now, you will always get it. But if you worry about plus and minus, just remember that you take the capillary pressure. You take the capillary pressure and minus capsule pressure. Capsule pressure, all of it. Now, capillary pressure we have in every capillary. One is hydrostatic, one is oncotic. Here too, we have one is hydrostatic, one is oncotic. Very simple. You plus these two you plus these two, and you minus capillary minus capsule. Very simple. Very simple. Positive predictive value deals with sensitivity. We have a video about it. Don't just watch the video, or just remember this thing, that positive predictive value deals with sensitivity. What is a it's really hard to explain all these things. Anyway, just first one, and you will see that others are almost same. See, what is positive predictive value? If we do RT-PCR for COVID, and we say positive predictive value of RT-PCR is 7%. That means if we get 100 positive results, okay, if we get 100 positive results, 7 people will have the disease. Out of that 100 results, have the disease. Or if we do that test 100 times on one person, 7 times we will get it positive. I'm just telling you all the way they can say it. We will get it positive. Or if we do this RT-PCR on one person, he has 7% chance of having the disease. Having the disease. That means, okay, let's say if we do P24 test and its positive predictive value is 20%. That means if we do P24 on a person and it becomes positive, that means that person have 20% chance of having the disease. And if we say we do a P24 test and the positive predictive value is 100%, that means we do P24 test one time on one person and 100% sure that he has HIV. Very simple. Granuloma in sarcoidosis, non-caseating granuloma, sometimes they say non-necrotic granuloma, same thing. Acute pancreatitis presents with acute pancreatitis patient presented with ITC, developed necrotizing pancreatitis, NG output is increased more than 8,000, mode of feeding. Okay, guys, so what do? You do, so you cannot do NG because necrotizing pancreatitis and NG output is increasing a lot. So if you do gastrostomy or jejunostomy, those will not help. You go for TP and you rest the gut a little bit. Rest the gut. Very simple. Very simple. Then afferent. Why do we use TPN? Why do we will have more questions and we will explain those there. Afferent of gag reflex, guys, just correct it. Gag reflex. We all know. What did I tell you? Anytime you go to see a tonsil in a baby, what do? Tonsil are in our pharynx, and there is one nerve that has P or pharynx in it. That is glossopharyngeal nerve. Glossopharyngeal nerve. It will take touch, pain, temperature from posterior one third of tongue and pharynx. So anytime you touch your pharynx, anytime you touch a baby's pharynx to see his tonsil, that sensation will be carried to brain by glossopharyngeal nerve. And if you touch it harshly, or too deep, or if you too deep, that person will gag. And what is the afferent limb of gag reflex? This is your brain, and you touched the pharynx, and glossopharyngeal nerve will carry the sensation to brain, and brain will tell you to vomit with vagus. So it took the sensation that is afferent, that is afferent, carried by glossopharyngeal nerve, and efferent or exit is with vagus nerve. Very simple. Efferent or exit is with vagus nerve. Female with history of prolonged labor and instrument assisted delivery now presented with continuous dribbling of urine from vagina. Very simple. See, stress, urge, mix, stress will be during any stress. Like you lift heavy object, lift heavy object. Urge, whenever you have a full bladder and you will have an incontinence, full bladder, but this is continuous. Continuous discharge only comes from fistula. So that's a vesico-vaginal fistula. No doubt that is a vesico-vaginal fistula. No doubt. Maxillary sinus roof is formed by floor of orbit. Very simple. We have it in our head neck surgery class. Just see, just see orbital floor. Just see orbit, boundaries of the orbit or formation of orbit. Just see, that is important. You don't need to know maxillary sinus boundary. We get it wrong here. We don't need to know maxillary sinus and all the bones around it. No, we need to know orbit. We need to know orbit and the bones forms it. Just give a look. Patient with atrophic gastritic autoimmune disease. Do you remember how many times I have told you that what kind of RBC will be there? How many times? And this is so beautiful. These questions come the same way I tell you in our classes. And let me recap what I told you during our classes. I told you that if we have any antibody against our parietal cell in our stomach, what will be the problem? See, atrophic gastritis, gastric gastric cells will be atrophied due to an antibody, and it's autoimmune disease, always autoimmune disease. Now what happens anytime there is an antibody against parietal cell? What do we have? We have parietal cell, we have a chief cell, we have other cells. Anyway, just see it from our git physiology. Now what happens? Parietal cell will release hydrochloric acid and intrinsic factor. Very simple. Most just remember now, for now, intrinsic factor. Intrinsic factor is very important. Why is that important? Intrinsic factor will go to your last part of ileum, that is your terminal ileum, and intrinsic factor is the gate for vitamin B12. Intrinsic factor, if if is not there, B12 cannot be absorbed. B12 cannot be absorbed. B12 coming from food, intrinsic factor coming from parietal cell, and here is the tissue that's waiting for taking B12. Okay, but intrinsic factor is the gate for B12. Intrinsic factor will take B12 inside the tissue and it will transport it to our bone marrow. And there we have erythrocyte megakaryocyte family. Erythrocyte megakaryocyte family. And what will happen? We will get RBCs, big RBCs, and then they will mature and get their characteristic shape. Okay. And who does that? This B12 that came, this will press from all sides of RBC and give its characteristic shape. That means B12 will cause RBC to mature. So, if B12 is not there, what will happen? These RBCs will not get matured. These RBCs will not get its characteristic shape. Then how will it be? It will be big. We call it blast. Okay, we call it blast. And these are oval, big and oval, big and oval. What do we call it? These are big. We call it megaloblast. Okay, we call it megaloblast. Large and oval, or big or oval, we call it megaloblast. And when this megaloblast comes into circulation, what will happen? We have spleen that undergoes, where it undergoes routine checkup, and the young, beautiful, flexible RBCs will pass its pulp very flexibly. But when these large and oval RBCs come, they cannot pass the test. They cannot pass the test, and they are distracted by macrophages. So we get low RBCs, and that will cause anemia, and we term it as megaloblastic anemia. Megaloblastic anemia. And the characteristic shape of this anemia is large and oval RBCs. Large oval RBCs. Reason? B12 deficiency. No other reason for this. Folic acid, don't worry about it for Mrcs part A. Just remember B12 deficiency. The way I told you. Then 60% bar cases with bilateral leg edema. What is the most common cause? We all know it. Albumin. Albumin. DVT, no. Albumin. Because 60% burn. 60% burn. All the proteins of your body is burned. So after burn, if there's an edema, it's due to hypoalbuminemia. Just memorize this information. After burn, if there's an edema, that's hypoalbuminemia. Now, conus medullaris level in adult, nothing to talk about it. Just see our neuroanatomy PDF. Neuroanatomy PDF. Numbness in lateral distal arm, forearm and thumb dermatome. Forearm, thumb. Just thumb is your keyword. Remember thumb, C6. Remember middle finger, C7. Remember little finger, C8. Very simple and easy. Okay, and just see the dermatome picture from our diverticulum contains pancreatic tissue. Histopathology will reveal. Just memorize it as it is from our arrows. You will find it in our arrows. You will find it in our arrows. Flushing, palpitation, carcinoid. Carcinoid. Just test for carcinoid. Test for carcinoid. Nothing to explain from our arrows. We have it in our pathology, but right now don't go through all the notes. Just study the arrows. Furosemide and thiazide action synergistic from our arrows. They do the same thing. They do the same thing. Synergistic action. Open appendectomy done for acute appendicitis. Patient presented with sign and symptoms of surgical site infection. Remember, any surgical site infection. Any surgical site infection. Staph aureus is the most common cause. Ideal place for lumbar puncture. We don't know what came. Just see the plane. Just see the plane. Just see the lumbar puncture site L45 and at the level of iliac crest. We all know it. Patient with diarrhea and uncontrolled hypertension. Uncontrolled hypertension. Uncontrolled hypertension. What is the feature of men 2A? See, we all know what are they asking. They're just asking among these, which one is the feature of men 2A? Just remember from pathology, just few days back, I told you in our pathology 3 class, pheochromocytoma. Okay, pheochromocytoma. Now, is the cause of hypertension. Is the cause of hypertension. Just see men 2A. Just see men 2A features. Okay, you don't need to study this question. This question is unclear and people don't know what they said. They just said that feature of men 2A, and we really don't know what came and what were the options, because we don't trust people, because that's not a problem. Actually, you can't trust you can't trust because there are 300 questions, and this is impossible that you remember 300 questions with 1500 choices. Not possible. Not possible. So just study about men 2A. 32-year-old athlete comes with stiffness and back pain. On CT scan, the space between transverse process of vertebra is reduced. Spondylolisthesis. Very simple. It's very simple. Transverse process of vertebra is reduced less than 2 centimeter. We didn't attach a photo. Okay. See, ankylosing spondylosis. Keyword is bamboo vertebra. Stiff vertebra. Okay, stiff vertebra. Rheumatoid arthritis? No, they will not give you this scenario for rheumatoid arthritis. Never. No. Vertebral disc prolapse? No, they will tell you that there is prolapsed disc in MRI. Prolapsed disc. Now, if a disc is prolapsed, that will compress a nerve, and they will tell you a shooting pain. They will tell you about a shooting pain along the distribution, but they didn't say it. They just said that transverse process of vertebra, the space between transverse process of vertebra is reduced. So that is spondylolisthesis. We have picture of spondylolisthesis. Just see it, you will understand it. This is not so hard. Okay. CKD patient means renal impairment. Very simple. Any CKD or renal impairment, if mentioned and you need a CT, remember go for MR angio. They just need to know that if you know that you can't use CT in renally impaired patient, because if you need to use a contrast, you can't do that. So anytime you see imaging question in a CKD patient, be very sure they are asking about MR, MR angio or MRI. Okay. Tricuspid valve, tricuspid valve repair got after a tricuspid valve repair, maybe after a tricuspid valve repair, got heart block. What is the affected structure? See, tricuspid valve. We have four valves. We all know. Right atrium, right ventricle. Left atrium, left ventricle. Okay, between right atrium and right ventricle, we have tricuspid valve. Between right ventricle and pulmonary trunk, we have pulmonary valve. Just to recap, we all know still. Left atrium and left ventricle, we have mitral. And from left ventricle to whole body, we have aortic valve. So, and we have AV node here. So, after tricuspid valve repair, if you have a heart block, you must have damaged the AV node. Tricuspid valve closure. Just see our cardiac cycle chart. Cardiac cycle, isovolumetric contraction. Non-smoker diabetic patient presented with punched out ulcer on dorsal surface of hallux. On examination, the foot is cool, not the cold. Foot is cold. Anytime, anytime your foot is cold or an ulcer with a cold periphery, that is an arterial ulcer. That is an arterial ulcer. Very simple and easy. Very simple and easy. Young stable patient with flail chest presented next day after RTA. He is vitally stable. What do you give? Guys, see, here is the magic. We have told you in class, and you have seen in recalls and everywhere that give BP again, BP again, BP again. Guys, see, erector spinae. We have a flail chest. Erector spinae is a back muscle. Will you get so blind in the exam that just by seeing bupivacaine you select that? No, you don't do that. You use lignocaine. Okay, you use lignocaine. Okay, guys, let's just finish it up to 77 today. I will start. We have 3 days. We have kept 3 days for September 24 because we will describe it all. I will take from 78 tomorrow. Okay, guys, have a good night and revise, revise, and revise.